Here we are at the American Academy of Ophthalmology. I'm with Sheraz Daya, pretty smart guy from the UK. We just got back from ESCRS. What have you learned while you're here? I know you presented the data on looking at trifocal lenses, whether it's a prolate or an oblate cornea. Can you kind of summarize what you found?
Yeah, so I don't think it makes a huge difference, and I've indicated in the past why. When we see patients after they've had the lenses removed, the average pupil size is about 4 to 4.5 millimeters. So when we measure aberrations, we're measuring that 6 millimeters. That's the ANSI standard,
Right?
And that kind of pulls us into perhaps not wanting to do advanced technology lenses in these patients. Well, since 2007, I've been putting diffractive lenses in these patients, and we've done a large number. We stopped analyzing because the data didn't change. When we analyzed 108, when we analyzed 350, and we took it to 400, and there were about 125 data points per eye we were looking at. It didn't make any difference in terms of answer rates, visual outcomes. And what we found was you'd expect, because using an aspheric lens, we use the standard diffractive lenses, which are all negative, they all have negative asphericity, right? And the question is, are we doing the patients harm by putting them in ones that have had previous hyperopic LASIK or hyperopic TRK?
Right.
And to our amazement, the ones that did better were the hyperopes.
Yeah.
They're negative spherical aberration, along with a negative spherical aberration lens. But they had better contrast, better visual quality, and you'd have expected neutralizing the positive spherical aberration and myopes to have done better, but they did.
Now,
something to read in.
Only to go a little different with him is we did a similar study. The only difference, I totally 100% agree, is that we saw a few more 2010s, a few more 2012s and 2016s on that front in terms of how they see. Now, most of my patients, because I've done like 86,000 laser vision corrections, are post-refractive patients. Do you think there's a difference between a post-refractive patient and a virgin cornea?
Yeah, there is. I mean, I think that it's all about patient selection, right? So the two aberrations we worry about, in one in particular, is the asymmetric aberration, coma.
Right.
So if it's a small decentration or whatever, that can really be visually destructive.
Right.
At the best of times. And that in those cases, all I do is use an aberration-free lens.
Right.
But they're happy with that.
And are you doing any kind of mini-monovision with that and those aberration-free lenses for those guys or not?
They want to fraction you.
Okay. And a fraction is...
It's kind of easy. They've got the IOL power correct.
Yes.
And have them handsome. So... I mean, that's another topic for another discussion.
Yeah.
But it depends on the patient.
Yeah.
The British patients don't like monovision much. You're asking about Presbyond and Supracor. Yeah, I do it.
Right.
We're the only guy in the UK who does it. But I really have to select those patients very, very carefully.
Yeah, and I think we know it works because friends of ours have had it done, right? But I think that it's another compromise that people will do. Now, we have a few moments left. Is there anything that really excited you while you're here in America?